So we are going to talk a little bit about brain tumor treatment. I'm going to focus on some of the issues when we think about radiation. And a lot of people may sort of gloss over this as, okay, let's just send it for radiation. But there's a lot of details in the topics that may impact on your patient and their quality of life. And I want to talk a little bit about how this has evolved over time. And as patients are living longer with this disease, we need to think about doing the best we can for them. And that means being sure we get modern therapy. So I don't have any disclosures. I'm going to talk a little bit about the history of how radiation has evolved, and particularly the volumes and doses. And then I'm going to talk a little bit about how we are now able to safely retreat patients that have local tumor progression. And Bert's going to talk a little bit more later about the medical management. We're also going to hear about basic science and translational research in these areas. So if we go back and we think about how radiation oncology for glioblastoma has evolved, we have to think about studies that were started in the 1960s. And these were planned based on autopsy studies and perspectives that were before CTs and MRIs were even in place. So all patients that were enrolled in the initial clinical trials evaluating the possible role of radiation therapy for glioblastoma were in the pre-CT era, and patients received whole brain radiotherapy. They received very high doses to the whole brain, 60 gray. So we don't even use that dose anymore to the whole brain, even for other conditions. And we would consider that to be too much, perhaps, in most cases. It was later in the 1980s that we switched to a partial brain treatment. We still didn't have good imaging. It was really crude CT-based, and large margins were generally utilized. We still have a foot in that area, even though the imaging has really improved. And there's been controversial as to whether we need to treat the edema around the tumor because it's microscopically infiltrated, or that we can do something a little bit smaller and perhaps easier on the patient. So if you look at modern trials all the way over here, let's use this pointer, all the way over here to the right, they would allow whatever method of radiation planning the investigators prefer, whether it was treating the edema intentionally or just treating the enhancing abnormality. And I'll give you some idea about where we stand at UAB, but we believe that we can be more conformal and smaller in general. So if we go back to Brain Tumor Study Group 6901, this trial was started, or at least planned in 1969, and this was before even good CT imaging was available. Whole brain radiotherapy was compared to supportive care, chemotherapy alone, or a combination. And you see here that for this mixed group of patients with an anaplastic glioma, including grade 3 and 4 tumors, they lived longer if they got one of the two radiotherapy arms. So that was the study that really initially defined radiation as being the standard of care for glioblastoma. Whole brain radiotherapy, very high doses. Since then, there's been a lot of attempts to change the way radiation works, either through doing brute force radiation, dose escalation, radiosurgery, brachytherapy, some fancy type of particle, or some biologic response modifier. And you can see that this table of negative randomized trials, about half of them were attempts to change the way radiation was utilized. And in general, brute force radiation by itself has not improved overall survival for this disease. And you could argue really hasn't even changed the pattern of local tumor progression. So 60 gray to some volume in general over 6 weeks is the standard of care for newly diagnosed patients. And this goes back in terms of what we should treat to, I think, really this paper from 1980. And these are two neurologists from Massachusetts General that did an autopsy and CT study, and they said, what are we doing with radiation? Why are we giving whole brain? Is it really necessary? So they went back and they correlated CT findings with autopsy. And at that time, they said there are 3 assumptions to radiation oncology, radiation therapy planning, and we don't think any of them are true. So let's go through these. There's no radiologic technique that provides accurate delineation of the tumor bulk. This is pre-MRI. CT, they said, maybe is okay, but historically they said there's no test that we can do to find all of it, so the radiation oncologists want to treat everything. Glioblastoma is commonly multicentric, therefore we need to treat everything. A major source of therapeutic failure is recurrence beyond the radiotherapeutic fields. probably all these things are wrong, and that's what they were saying in 1980. So they had the CT scans. They found that 90% of the recurrences were within 2 centimeters of the primary tumor. That's grossly and microscopically at the time of autopsy that they compared this. The people that did not have a recurrence identified by CT, 4 of the 6 had autopsy evidence of subependymal spread. So that's a minority, but it does exist. And I'll show you some of that in our own data in a few minutes. So this was one of the 2 or 3 papers that said, you know what, we can give partial brain irradiation probably. This is another one, and this is an example of how crude some of this literature is. Kent Walder, who was at Memorial, he's better known for prostate cancer treatments now, did this study. It was published in the 80s, and he took the recurrences and the initial CT scan and compared them. And to do that, this is before computers were decent, and we could actually map out these things inside of a computer. He projected it on a wall and hand drew it out. And believe it or not, that's what changed the standard of care, was these types of studies, even though they're very, very, very crude. But what about clinical evidence this is okay? So this was made without a tremendous amount of clinical evidence that it was okay to switch from whole brain to partial brain. But this is one of the studies that influenced care heavily. Not published until 1989. And in the middle of the trial, they said, you know what, we don't need to give whole brain anymore, let's just randomize patients. So they were given different chemotherapies and then also 2 different radiation volumes. And it turns out whether you get the whole brain radiation in 1980 or 1981 or afterwards you were randomized, you lived the same amount of time. So they said the whole brain radiation doesn't have to be given. What about MRI? Can we find the right place to treat easier? Well, Memorial Sloan Kettering did biopsies of the flare, and they found, yes, we can see microscopic tumor in that area. That was part of the evidence that changing the way the partial brain was treated in the United States. We need to treat the edema because it has microscopic disease in it. And it, certainly you can see that in some cases, but in a lot of cases, the edema, we can't see tumor in that. So we need better imaging. So cooperative groups have evolved into 2 parallel groups or 2 parallel camps. Treating the edema or not, everybody's giving partial brain irradiation, and exactly what that means is controversial. So in the United States, the RT, led by the RTOG, you would see relatively large volumes of brain electively irradiated 2 centimeters around the flare or T2 abnormality on an MRI with dose of 2 centimeters, and that would correspondingly give you a larger volume. So probably over-treating some of the microscopic disease there. EORTC, a large volume on the enhancing abnormality, ignoring whether you have a big amount of edema or not, whether it's arising from a primary or secondary tumor, and whether any other imaging suggests that might be tumor. MD Anderson has retrospectively compared this, and it's clear that if you treat the edema electively, like the RTOG does, you treat the partial brain, the normal brain gets significantly more radiation. That makes sense. Dr. Obe and I were talking last night about a long-term survivor from glioblastoma and all the problems that he was having. So it may be that as we improve survival, and I'll show you some evidence that we're doing that we're going to have better quality of life from our long-term surviving patients if we can minimize this volume. So RTOG transition to partial brain irradiation, 2 centimeters to field edge was used in the 90s. Block edge is 50% of the dose. So before 3D treatment planning, you said, okay, where's the edge of the radiation? It's the edge of the field. Now it's actually the volume. It's volumetrically described. And we jumped to a 3-dimensional version of this, and actually the RTOG increased the radiation volumes during this era as imaging is actually improving. So they had 2 centimeters of dose plus a little bit of fudge for the actual, whether the patient's exactly aligned correctly. So radiation volumes have actually increased in the modern era from the RTOG. American Brain Tumor Consortium is a group of academic medical institutions that perform early-stage clinical trials in glioblastoma, and we are funded by the NCI. We've been called different things in the past, NABTT and NABTC, but the margins have always been much smaller, radiation volumes, 5 millimeters of extra tissue irradiated instead of the 2 centimeters, so it's a much smaller overall. We do use a 2-phase approach where we treat the edema the first 4.5 weeks of treatment, and then a boost to the enhancing abnormality. So that results in this treatment planning study, which was from Emory, 45% larger volume, 70% on the boost than what the RTOG is typically used, so significantly larger volumes. What about the patterns of failure if you do that? So we initially looked at that with temozolomide, because temozolomide is thought to be a radiation enhancer. It's now the standard of care for the last 9 years or so. And does it change the pattern of failure? Do these margins, are they adequate? And Chris Domelbauer at UAB looked at over 20 patients, and we had about 75% of our patients were infield only. And if you looked at infield and distant, that was about 90%. So in this case, you can see there's subependymal spread with the radiation administered posteriorly. This little guy was accompanied by other tumor in the subependymus. So this would be a patient that has an infrequent pattern of progression. Our colleagues at Wake Forest have done similar studies looking at different margins and have not found differences in patterns of progression based on how much extra brain they are radiating. And this is whether it's 5, 10, or 15 millimeters. They did not find that chemoradiation had a different pattern of failure than radiation alone before we were using temozolomide, which I found interesting. The one bit of evidence that says that may not be the case is in methylated patients. And this is the only study that I've seen that looked at molecular subtypes of patients to see if they are going to develop a progression. So patients with a methylated promoter MGMT methylation have a better prognosis. Perhaps the temozolomide and radiation is more active, and it allows them to live longer and more likely to develop recurrences elsewhere in the brain. In this study, over 40% of patients developed recurrences elsewhere in the brain that had MGMT methylated. So here's what we're doing outside of clinical trials and associated with the ABTC Consortium studies. 5 millimeters around the flare is our target, plus 3 to 5 millimeters for setup error. And then the boost is just on the enhancing abnormality. So we've looked at our patients at UAB, and this is a series of 95 consecutively treated patients. These patients received temozolomide-based chemotherapy with their radiation as described by the American Brain Tumor Consortium. These patients had about a third of them had a gross total resection overall. And this is what we would call a marginal recurrence. What you see there in purple is the dose color wash from the initial boost plan, and the patient failing marginally there. So our infield only is about 2/3 of patients. If we look at infield and distance, it adds up to about 80% of patients having a component of progression infield. Our subependymal spread or distant only spread was a little bit higher with a larger set of patients overall. So I think as we develop better local therapies that we're going to see, and patients are living longer due to better salvage therapies, we're going to see more patients with diffuse spread at some point in their disease process. And we'll see that in some of the Avastin data I'll show you in just a minute. So if we're going to do these types of studies, we have to be able to interpret our follow-up imaging. And I think Dr. Neighbors is going to talk about the RANO criteria a little bit later on. But we get irritation of the tissue. It bleeds contrast. We see new enhancement after chemotherapy and radiation. You can call it necrosis, you can call it inflammation, you can call it pseudo-progression. This is a process that looks worse on the scan. The patient may or may not be clinically worse, depending on mass-affected edema. But without any intervention, some of these patients get resolution. So this is just one example case where the patient was treated. Gosh, this looks like progression here. See how this is kind of foamy and has an indistinct edge? We think that's more associated with pseudo-progression, and this would be watched, and in fact, just staying on adjuvant temozolomide, patient got better. So this is a case where it's very difficult by MRI sometimes to tell what's going on, so the RANO criteria will utilize. Bevacizumab makes this even harder to understand because it changes the enhancement pattern, and you can get worsening on the flare abnormality. Bevacizumab is an anti-VEGF monoclonal antibody. It decreases steroid requirements. There are 2 randomized trials we'll mention later in the talks. that did not show an overall survival advantage. It is FDA approved for the treatment of recurrent glioblastoma multiforme, and that's how we've been using it in the clinic. But if you have bevacizumab treating this enhancing abnormality at failure, getting better, you've got to look at the flare abnormality also. Initially improving, but later progressing despite the enhancement looking better. So this is why assessment of bevacizumab-based patients may be different. And if we're going to retreat these patients, we have to understand where the tumor might be. So Dr. Neighbors will probably talk about this a little bit more. But this RANO criteria has been put in place as a research and assessment tool for whether the patient is in remission, how they're doing stable disease, or if they've had a complete response. It's particularly relevant for defining pseudo-progression in an objective, standardized way, and how we evaluate therapies that change the contrast enhancement, but may not really change how much tumor is actually there. So I'm going to skip some of this. After chemoradiation, it requires a 12-week assessment before you can call something a progression, unless it's progressing outside the radiation zone. That's because of the pseudo-progression. There's been only one study that has looked at patterns of failure with bevacizumab in newly diagnosed patients. This one's from Virginia. They only had about 20 patients and 12 evaluable for imaging at the time they had done this assessment, but 5 of the 12 had subependymal progression in newly diagnosed. So that's clearly going to be something that may be different if we're given bevacizumab. This is an agent that it treats radiation necrosis. This is a lung cancer metastasis that blew up and swelled after it was treated with high-dose radiation, and you can see got better with bevacizumab. Same thing happens in gliomas, and it is beneficial. 2 studies were published in the New England Journal of Medicine last month in February, looking at the role of bevacizumab in newly diagnosed patients. Neither showed an overall survival advantage. I have here the progression-free survival with a trend for the bevacizumab patients getting this monoclonal antibody in addition to chemoradiation. But both the trials look about the same overall. Interpretation of these differences in progression-free survival is slightly different. Here's the EORTC results, similar finding. There's interest in re-irradiating patients. If this agent can treat necrosis, can we retreat patients and have a lower risk of toxicity? And so this has been explored in 2 prospective trials. This is from Memorial Sloan Kettering, which was a phase 1 trial. And they found that given 6 grade times 5 to small targets with bevacizumab was very well tolerated. And they had about progression-free survival about 6 months continuing bevacizumab and radiation. Now, bevacizumab can be used as a monotherapy with radiation, or radiation can be used as a salvage, either one. This is from Duke. They gave a single fraction of radiosurgery if you had a small target, or 5 fractions for larger, up to 5 centimeters. And they found retrospectively patients that got bevacizumab lived longer and had better progression-free survival. So their standard is the combination if they're going to retreat somebody. And I think that's what most places would say. At UAB, here's what we're doing right now. If you have no research protocol option in the recurrence setting, we would offer you bevacizumab. And this could be hopefully more than 6 months since your prior radiation. Hopefully you benefited from radiation the first time and you're further out so that it might be safe. We will often give a cytotoxic chemotherapy agent with this, depending on what the patient has had and tolerated in the past. And we treat tumors up to 6, or targets up to 6 centimeters. If the patient is not on bevacizumab, we're treating usually the enhancing abnormality as our target. If they're on bevacizumab and develop new enhancement, I think that we're underestimating the target by treating only the enhancement. So we think about the flare and is there really active tumor in there? It's just not showing up as much. The patient has involvement of the brainstem or optic nerves. We usually don't re-irradiate those with hypofractionated dose films. So those are treated with longer courses of radiation in the retreatment setting. So we've treated about 23 patients with this, and this experience has been written up right now, but there's only been 1 patient with grade 3 radiation toxicity. All the other patients have done very well from a toxicity standpoint. We would have estimated historically we'd have 30 to 50% of patients with grade 3 toxicity without bevacizumab, so it's clearly safer to administer. And you can find anecdotal patients. We'll show this case later. This patient actually over the course of 3 years had 4 different courses of radiation. So they are able to be retreated if a new area is showing up in particular. The role of radiation with bevacizumab is going to be defined probably by this trial in the United States. And we'll be looking at this from the RTOG. Patients are randomized in the recurrent setting with bevacizumab or a combination of bevacizumab and radiation. The radiation dose schedule is 10 fractions, so 35 Gray, so a little lower than is used in some of these other trials. But this will tell us whether radiation is delaying progression at that site or has a survival advantage. Some of you may be kind of pessimistic about glioblastoma and the progress that may or may not be made in this disease. And I hope my colleagues that speak after me will give you some hope that the biology and the medical therapies are advancing. But here's a little bit of information. So this is how we're doing in our consortium. And if you look at the pre-temozolomide era, we have this median survival of about 12 months. These are big academic medical centers that specialize in treating brain tumors. In the temozolomide era, it goes up to 15, 16 months, and that's about the same as the standard arm in EORTC study with temozolomide. The last 3 phase 2 trials that have been run in the consortium, median survivals have ranged from 18 to 20 months. So we think it has significantly increased, and there's multiple reasons why that may be the case. But it's not just that we have only one new drug in 30-some years. I think there's better care overall across the continuum, better surgery, better radiation, better imaging, and some medical therapies that help the patients as well in the recurrent setting. I think long-term, we're going to be looking at better imaging for radiation planning. Here's just one example. This is a carbon-11 methionine PET. So regular FDG PET, there's a lot of uptake in the brain because we're using a lot of sugar. So it's hard to see an actively metabolizing tumor within a brain that's actively metabolizing sugar as well. So we look at other agents, perhaps in the brain, such as methionine. You can see here is the enhancing abnormality. This is where the PET says the tumor is, and this is where the flare says the tumor is. So probably the flare is overestimating, the T1 post-contrast is underestimating, and maybe this is just right. They treated patients with dose-escalated therapy at the University of Michigan with this regimen, and they found that patients lived about 20 months, and that they had some people that could retrospectively say, yes, the recurrences are occurring right where the PET retrospectively said it should. So it was identifying recurrent tumors before they had grown. And in fact, of the 7 of the 8 patients that were retrospectively thought to have not had the PET abnormality covered, they developed non-central recurrences. So we could use some of these imaging modalities to improve the radiation targeting. Whether this translates to overall survival advantages remains to be seen, but clearly we could give less of the brain treatment if we have better imaging overall. So I'll start to conclude there that the partial brain radiation remains the standard of care, and exactly what that means people can debate. I suspect that the ASTRO guidelines will reflect that clearly an option to treat something smaller than what we've treated in the past. Those guidelines are still being written this year, will likely come out at the end of the year or early next year. I expect that novel imaging, such as the methionine PET that we talked about, is going to play a role in helping us understand what needs to be treated and what doesn't. Ultimately, I suspect that we're going to get better local control through biologic modification of the radiation response, and that we're going to see more diffuse progression in the brain as sort of the next step of the progression. So each time we change radiation or the drugs that are given with it, we'll need to repeat these studies in order to understand that we're treating the right volume. So ultimately, this is thought to be a whole CNS disease, and that we're going to see problems in the central nervous system developing. In the recurrent setting, studies like RTOG 1205 will be required if we're going to understand the right timing of retreatment. I think it is something that's safe, and if patients don't have critical options, it's something we're offering outside of the clinical trial right now. So I'll thank you for your time, and I think, are we going to have questions later or now?
Any questions?
Okay. Any questions? I got a question over here to the right. Yes.
You said going on with hippocampal sparing in trials at UAB or elsewhere.
So he's asking about hippocampal sparing, and there's a hypothesis that that will improve neurocognition. We participated in the RTOG study, which was a phase 2 trial of metastasis treatment, and it's a more expensive way of giving whole brain radiation. They found in the phase 2 study, compared to retrospective or historical controls, that they had improved cognition. So the hypothesis that hippocampal protection, or taking that into account at the time of radiation planning, will be tested in a phase 3 trial in the setting of prophylactic cranial radiation for small cell lung cancer. So patients that are getting brain radiation for non-metastatic small cell lung cancer, they're going to try to treat microscopic disease and look at it in that patient population. Other questions? Yes, sir.
Yeah, what's the role of stereotactic radiosurgery in recurrent GBM?
So the question is, what is the role for stereotactic radiosurgery? And I assume it's referring to single fraction treatment. So the Duke trial used single fraction study with Bevacizumab. Historically, I would say that we have about a 50% radionecrosis rate when Bevacizumab is not utilized. So I don't like using radiosurgery for salvage without a VEGF inhibitor. But I think it's more toxic. We have done the 5-fraction regimen because we think it's been very well tolerated, and wanted to get more experience in understanding whether that's the right thing. I don't know for a smaller target, 1 or 5 fractions, whether it's the right number. But I think clearly, given with Bevacizumab, it will play a bigger role than I think in the past. We use it when patients don't have a clinical trial option. If you look at overall, we've treated about 5,000 patients with our Gamma Knife. Fewer than 1% are gliomas. So it's infrequent treatment in UAB. Other questions? I'd like to thank you for spending the morning with me, and we have our next 2 speakers from UAB. We'll hear about translational oncology and clinical medical oncology advances next.